Good afternoon and welcome to Vein and Lymphatic University. Victor Canada and myself are broadcasting from the National Medical School here in Asuncion, Paraguay. We're going to be talking today about aesthetic sclerotherapy indications and procedures. Today we have Lina Vargas, who's going to be our main speaker. Lourdes Gutierrez from Spain will be also talking as a discussant, and Annalise Rodriguez from Brazil will also be talking as a discussant. So I'm going to turn the floor right over to you, Lina, and please share your screen.
Thank you. Can you confirm that you see the screen okay?
We do.
Perfect. All right. Let me know if at any point you stop seeing it or if you stop hearing. I'm very excited to be here. I want to thank you for the invitation to participate on this webinar today. This is a topic that is very dear to my heart. I am a vascular surgeon, originally from Colombia, trained at Cleveland Clinic, and I devote my practice to vascular vein treatments. I gave up my arterial practice a few years ago, and this is an absolute passion for me. My clinic is located in Orlando, and I practice full spectrum of vein disease as well as aesthetics. And today we're going to talk about cosmetic sclerotherapy indications, discuss a case, and just kind of share a little bit of how I do it. So as we all know, reticular veins and telangiectasias are a visible sign of a venous disorder, and they can be present with or without superficial or deep venous insufficiency. And they can be completely asymptomatic, or they can also be associated with symptoms like pain, pruritus, burning, sometimes even bleeding, or signs and symptoms of chronic venous insufficiency. These lesions are usually located in the subdermal space or in the subcutaneous tissues. And they, like I already said, they can be essentially isolated. They can happen spontaneously. They can happen after trauma. But most times we tend to see them in association with some deeper venous conditions. The incidence increases as we age, definitely more common in females than males, and they represent a pretty significant cosmetic concern on majority of patients. And I think nowadays we're seeing a shift where male patients are actually very, very concerned about them and are seeking for treatment, whether as independent or as part of treatment of their medical conditions as well. So important considerations before trying to treat these lesions. And I think this is one of the things that separates us from most of the practitioners that are treating these veins worldwide nowadays. I am not opposed to other physicians who are not necessarily vascular surgery or vascular medicine trained, because there's so much anyways that I don't think we could all be able to deal with all of them. But I do think it's important that we, as we find these physicians or these practitioners that may not be as aware of the venous pathology that may be underlying, that we share and educate. But this is what really separates us, is being able to have these conversations with patients, because it's not just about being able to get into a little vein and inject a medication or use a laser to treat them. We need to really figure out if someone has a deeper issue that needs to be addressed, not only because it's a medical condition, but also because it's going to completely affect our results in terms of whether we're even able to treat them and get them the result they want, but also in terms of the durability long term. So we are all very familiar with chronic venous insufficiency as far as symptoms of swelling, pain, heaviness, fatigue, cramps, restlessness. All of these things are just very important, because obviously I would highly recommend against cosmetic sclerotherapy if we have any of these symptoms before doing an evaluation clinically and with ultrasound, and getting a good family history as well. So once we have that, then we can take one of two roads. If our evaluation and our ultrasound shows that we don't have any insufficiency that we need to worry from a medical standpoint, then we can proceed and talk about sclerotherapy and talk about the different alternatives. But if we do find that there is an abnormality from that superficial or deep system that warrants treatment, then we should go ahead and do that first, again, because it matters from the medical standpoint, but also because it's going to affect our results. It is obviously very important to understand who shouldn't get sclerotherapy in the first place. And Thankfully, majority of our patients are going to be candidates for it, but those who have any acute or any acute issue like a DVT, an acute DVT, or if they have any conditions on their skin, any infection, any irritation, we should totally stay away from doing that and just waiting for that to resolve. Patients who are pregnant, obviously, then we have the issue of patients who have severe migraines or who have PFOs. Not necessarily not a candidate, but just something that we need to think about specifically about how we treat them. Are we using foam? Are we using liquid sclerosants? Obviously, those who have allergy to sclerosants, although, I have to say personally, in all of, my over a decade of doing this, I've never encountered one, but I would love to hear from all of you if you've encountered this. I've never had this issue with allergy. And like I already said, skin infection, skin breakdown, just, stay away from that, make sure that that's cleared up. And patients who have arterial insufficiency are relative contraindication. Obviously, those who have mild disease absolutely can have it. There's no contraindication to compression stockings and potentially doing this kind of treatment. But if we have someone obviously who has, advanced disease, then probably we shouldn't be thinking about treatment of cosmetic spider veins or reticular veins in that setting. So the goal when we do our treatment is we want to achieve damage, complete damage of that endothelium that eventually leads to vessel fibrosis. And the ideal way of doing that is finding the right sclerosant in the right concentration, in the right amount for that specific vein, where we're really going to be able to damage that endothelium in a 360-degree fashion that is going to lead to fibrosis. Usually that fibrosis starts about 2 to 3 weeks following treatment. That's when we start seeing the fibroblast in the media. And then eventually that leads to complete obliteration of the vein. Now, what we want to try to avoid is to end up with not enough damage of the endothelium and thrombus formation, because that thrombus is actually going to be cleared by normal processes of fibrinolysis. That thrombus is going to get cleared, and that vein or that vessel can recanalize. And so it's trying to find that nice mix between having the right concentration, right volume, right pressure, where we really completely damage that endothelium without leading to thrombosis that then recanalizes. So technique varies, and we all know, we all have so many different techniques and different sclerosants and different methods, especially worldwide. We see a lot of variability, but in general, especially for those starting out, the needle sizes tend to be 27 to 32 gauge for the telangiectasias and 25 to 27 for the reticular veins. I always say, try to go with the largest one that you think you can use for your specific veins, especially if you're using foam. I think that is especially true if you're using foam. And then picking between foam and liquid, again, the concentrations, the injection pressure, and potentially the use of things like transillumination that's going to facilitate our treatment. So sclerosants, it depends on where you are, but have detergents like polydocanol and sotradecol. There's hypertonic saline that has been used forever. There's glycerin. So everyone kind of picks and choose whatever they feel most comfortable with, understanding that, for example, with detergents, it is important to use lower concentrations with smaller veins. So in my case, for reticular veins, I may be more okay with using 1%. I would never use 1% on a telangiectasia. Like it's going to be too much. Same with my pressure of injection. And this is something that actually comes with experience, because there's no way that I'm going to be able to measure and tell you how much pressure I'm applying when I'm injecting. But if you think about it, the more pressure, it's very tempting when you're injecting and everything is clearing out to just keep going, because it's very satisfying. But I would actually urge you against doing that, because you are putting more and more pressure. Remember, when this sclerosant goes inside, it's going to lead to venous spasm, vein contraction, and that is going to increase your pressure. So you're going to have to put more pressure for that sclerosant to keep clearing that lesion. I would urge you to just come out and go somewhere else, because that is going to lead to vein wall damage, and you can actually have extravasation, and that leads to one of the complications, which is hyperpigmentation, which is not insignificant. I personally like foam, the benefits of foam, especially the larger telangiectasias, larger reticular veins, because anytime you're going to inject liquid, it's just going to get diluted with blood, and you are not going to get that 360-degree contact that we want. So the foam actually has a piston effect that it's going to able to push the blood and really displace it. That's what we want. We want to displace the blood. So those micro bubbles come in contact with all of that endothelium and lead to the damage that we need to achieve. It's going to be distributed in a more homogeneous way. And you can actually use lower volumes and have lower concentrations and still achieve the result that you're trying to get to. So I really, really like foam. Again, I still use liquid for the very teeny tiny ones, but for the majority, I personally really like foam. Now, that being said, I am in the United States. We're not as lucky as everyone else. You guys have fantastic agitators that are available. Those are not as widespread used here in the US. So a lot of us still just use the old-fashioned Tessari method, which obviously works, but it's just important to know little things to try to make it as good as we can. So using syringes that are that are silicone-free, doing multiple multiple passes between the syringes, at least a good 20, but obviously the more you can, better. Just turning your stopcock to make sure that you get like really good teeny tiny bubbles. The smaller the bubbles, the better it is. And use a combination with gas in a 1:3 to 1:5 ratio, more or less. And you can use room air, but it's ideal if you can use CO2 or O2, because obviously those are more soluble in the blood. Room air is going to have a high content of nitrogen, and we know that that can pose some issues in certain patients. So going back to transillumination, I just wanted to show you this example. So this is what we can see with the naked eye. There's obviously limitations to how much we can see with the naked eye. I always say it's kind of like you're looking at the tip of the iceberg, but you're missing everything else that's under the water. So I do like to use, in my case, the vein light, but obviously there's a lot of different transilluminating devices that can be used to optimize your visualization of these veins. And that is important because if you can see on the image, we can actually see the afferent and efferent reticular veins that feed into these complexes that are visible on the skin. And I could just go with a 30 gauge needle and get foam or liquid into this superficially. But I think that if I identify that nice afferent vessel that I'm seeing there with transillumination, then I can actually get clearance of this whole complex with a single injection. But it's not so much, patting myself on the back that I can get it with one injection. It's more understanding and knowing and having the certainty that I'm actually treating this whole thing in a more complete way. So afferent, efferent, because that is necessary not only to make sure that this clears out, which is the goal, but also to do it without matting, which is another one of the complications that we're going to talk about. So use a transillumination, whatever system you have available, they all work. I just personally use this one, works for me. When we do sclerotherapy, this is in general very well tolerated. Obviously, there's some pain associated with the little, pricks, as well as some burning sometimes from the sclerosant, but it is very well tolerated. Main things that obviously we need to watch out, just like with any medication, allergic reactions and anaphylaxis, which are very rare. You can definitely create ulcers if there is extravasation, which is rare, more with inarbented injection of more arteries, arterioles, more than veins. And then chances of getting DVTP are very, very rare. And then, as we know, there can be symptoms of TIA-like symptoms, CVA-like symptoms, and potentially migraines, especially on those who have PFOs or a history of migraines. It just seems to be more likely on them. Let's quickly touch upon the two complications, mainly matting and hyperpigmentation. Usually incidence for both is about 20%. And the main thing with these is that they tend, about 80% or so tend to clear out after a year. So we just have to really be patient and handhold these patients, but there's definitely things that we can do about them. Matting is really, really interesting, and there's different theories as to why this happens, but it seems to be mostly related to a closed afferent vessel, but an open afferent. So it means that there's still blood flowing into that complex, but it's met with obstruction from the closed efferent. So that creates an increased hypertension locally in that area. There seems to be an inflammatory theory as well as hormonal. They studied presence of estrogen receptors in the endothelium in some of these lesions. And then there's also a histologic evidence of presence of lymphocytes in the reticular dermis that also points to a more inflammatory. But regardless of the etiology, this is kind of how this looks like. You can see part of your complex is treated. You can actually see some of those closed vessels there. They have that, pigmentation. But you see all of that network of very, very fine red, teeny tiny blood vessels that wasn't there when you started. Patients usually say, I didn't have any of this. So like I said, most of these tend to resolve on their own, but I think the main thing, especially understanding that this may be due to a patent afferent vein, is to try to go ahead and treat that, whether that's with more sclerotherapy or potentially a micro teeny tiny phlebectomy of that afferent vein. The other thing is you can actually use laser for this, so that you can use intense pulse light as if you're treating rosacea, sort of like with a 560 nanometer filter, or an Nd:YAG 1064 laser can also be really helpful to help us address matting. And there's some studies that
Lina,
actually looked at the
Lina, can you wrap it up, please? Thank you.
Brimonidine really works very well. Hyperpigmentation, same, about 20%. Most resolve on their own, but the most important thing is just prevention, having good technique. I personally am very proactive with draining, so this is what I'm doing here really quickly. Any reticular vein that has retained coagulum, I drain it out. I like to try to get my patients the result they want much quicker, and I do like to flush it with some saline, just to try to get some of that clot out. And then as far as the treatment protocol, obviously compression stockings is up in the air, especially when it's the cosmetic part. But I do like to avoid sun exposure, limiting activity and exercise. It's questionable. I don't like to take my patients out of their routines. And then understanding that patients need repeat sessions about every 4 to 6 weeks to achieve ideal results.
Thank you for all of that. In 15 minutes, you summarized the textbook of sclerotherapy, and I appreciate it. I'm going to turn it over to Lourdes Gutierrez and comments and/or questions, and keep your answers short, please.
Yep.
Lourdes, you're on mute. So let's switch to Annalise Rodriguez, because Lourdes is on mute at this point. Annalise, I'm going to ask you a question, and that question will be on CLACS. And if you can just briefly describe the CLACS procedure, and then please discuss.
Okay, so basically the CLACS is the association of the transdermal laser, the 1064, together with sclerotherapy, normally the liquid sclerotherapy. In Brazil, we use it with dextrosis. I know they don't have this in US, but what we see is that we have like a synergic action of the laser with a lower intensity, together with a low to medium power sclerosant. So we have lack of adversarial events with actually a very good result in the end. So you do the laser and then you inject. What I see the most especially for when you're using sclerosants, that you have a limit, like a volume limit, and treating very, very large lesions, the amount of liquid sclerosant you need after applying the laser is around a tenth of so when you need like 5 ml, you can use 0.5. It's really, really different, the amount. So for treating larger lesions, I think it is the best option. So you can do it like more at once and finish your treatments earlier. And also with the pigmentation. So Lowe knows now, we just published the paper saying that especially for patients like lady patients or brown skin patients, the association of the laser tends to make a less intense pigmentation than when you use foam or just the liquid sclerotherapy alone. I mean, foam, that's what we compared actually.
So do you have questions of Lina or discuss what she said? If not, I will go to Lourdes.
Yes,
Comments,
I want.
questions.
Do you hear me lower? Yes.
Yes, very well.
Yeah, we can hear you now.
Thank you very much. Yes, I wanted to point out in the concept Lina said before about the key point of the strategy and the techniques to prevent complications and to obtain good results. That is looking for the reflux, proximal reflux, to prevent hyperpigmentation and matting, and do a technique with the lower volume and the lower concentration of sclerosant to prevent these most important complications. And of course, to do a complete medical history to have a very complete diagnosis that help us to obtain the best results and to prevent complications as a neurological complication, even ictus or very serious complications. And according to the CLACS techniques, is a very promising one with good results. We are waiting for more randomized clinical trials. We have got one recently from Egypt, and this is very interesting, but I am wondering about the cost of this treatment. Perhaps we have to do a cost effectiveness of this new technique, because the laser device is very expensive. I don't know if Annalise can give a comment on
That's,
this.
I think this is the main question when we talk about CLACS. But I think when you're dealing the cosmetic patients, I think that's what Lina do as is mostly. The small difference, the small amount like of time you use for this kind of patients, it might make a difference. So actually, it comes out to the type of patients you're treating, the kind of practice you have, because CLACS, it's actually it's for private practice in any means. As of now, I don't think it might be that cost effective thinking in public health or something like this. But in the private practice, nowadays, I for myself, for my patients, I don't make any distinctions in the amount that I charge for either CLACS or foam. I charge for my time. So it's pretty much included. And when I think I need to use foam for that specific patient, I do. If I need CLACS, I do it. And I think like for my practice nowadays, it works quite well. Maybe a few years ago, I wouldn't be able to afford it and not even get paid back. So now I get the payback. So it's worth for me. So that you must study it in your own practice, I think. It's
Yeah,
like
I agree with that. I have, for me, because patients a lot of times will come asking for laser because they're afraid of the needles or they're, whatever it is. And so it's whatever I think is going to be best for them. I have the laser, I have a 1064, I have an IPL, I have all of these things, but I charge exactly the same because I don't want them to decide on one versus the other because of what their fears or their what they're going to pay. I just want to be able to offer what I think is going to be best for them. And going back to the use of combination, I think the other thing is it's going to be interesting to kind of compare, because laser first versus and sclero after, or vice versa, because there's also some evidence that shows that that synergistic effect is, it's definitely like we're not discussing that. It's more, it seems like when there is foam first and then we use the laser, same thing, we can use lower energies, but it seems like the presence of polydocanol foam actually not only has an anesthetic effect, because we know polydocanol has a tiny bit of anesthetic effect, but also it seems like the presence of the bubbles from the microfoam increases the absorption of the light into the chromophore, which I think is really important as well. So I think it's just very exciting to see just the research that's going to be coming, and once we really like fine tune the techniques and then comparing which ones first, which ones later, because it seems that it's actually beneficial both ways. But
yes, I think the best benefit.
Guys, I'm going to stop you right here because the audience has a couple of questions. So the first one, please answer these very quickly. In your experience, what key factors most influence patient satisfaction after cosmetic sclerotherapy? And how do you manage expectations regarding long-term results? This is from Omar Esponda.
Yeah, that's a great question. I think I do spend a lot of time at the beginning with the patient setting up expectations. So I do tell them that it's going to take at least 3, most likely more, that where it's going to take time. It's a process. There's chances of side effects. Like, it's just all about communicating. I could extend on this, but if you don't spend that time telling them, they're going to perceive those things, like if they don't get the result after 3 months, and if they have pigmentation or any of the complications, it's just gonna they're gonna think that it's you have no idea what you're doing, and this is a complication. So absolutely worth spending the time talking about all of those things, and revisiting those every visit is very important. And I think patients, obviously, they want to see their lesions gone, but as long as they can see improvement, which I think photography plays a big role, because we as humans tend to forget even where we started. I see that even with patients who had massive varicose veins, it seems like they forget somehow that's what they had. So we take lots of pictures and we revisit those. So every time that they come, they see the improvement. If they see any areas of pigmentation, we reinforce that that is part of the process. We have the technology and the treatments to help them with that. And we're just, sometimes a lot of these things just require hand holding, but I think having a good relationship with your patients, having photography to really document the process, and just being there for them if unfortunately they do encounter complications, or it's taking a little longer.
Thank you very much. I am now going to ask Lourdes, and everybody else can chime in here. The question is, what is the maximum dose of polydocanol foam used for microsclerotherapy? And this is from Dr. Jaco.
Yes, as less as possible to get your goal. And it is recommended not to inject more than 10 milliliters for each session to prevent thromboembolic complications and neurological disturbances.
Is that liquid and foam,
Or
or is it
foam.
foam?
The problem
What about
is
liquid?
especially with foam. You can inject more volume of liquid according to the pharmacology.
There's a
The recommendation
dose
of
per pounds or dose per kilograms
Yeah.
that you can use for each patient, but I don't recall it by heart by now.
Yes, you
But
have to
that's
read.
like, it's the concentration, volume, and the weight of the patient if you're dealing with a liquid sclerotherapy with polydocanol.
Yeah.
Correct. So there's a last question. Which is the best sclerosant, STD or STS, polydocanol or dextrose? And this
Yes,
is
all laughing at the same time. I don't think we can.
Depends.
I don't think that we have an answer for that.
I think it's
glad
the best
you
for the
don't.
lesion. I always start with the least one, like depends, depending on the lesion, of course, but I always start with dextroses here in Brazil. And if by any chance I don't see any improvement, I might go for polydocanol for a very few patients. And when the reticular vein is a bit larger than 0.2, I go straight with foam. Otherwise, I keep with dextroses for like the majority of my patients.
So it's
In
kind of
my
interesting.
practice,
My experience, and I have a little bit of experience with sclerotherapy, is make sure you understand what drug you're using to the fullest.
Yep.
That's number one. Number two, then learn another drug and understand how each one of these react to a particular vessel size that you're using. With that being said, I'm going to thank everybody that's been here. We are going to continue on because we're right now at the medical school. For those that can stay on, that's great. For those that can't, that's also great. But I also wanted to talk about our next VLU Grand Rounds, and that's next Wednesday, same time, 12 o'clock. Should we prophylax everyone, and what drugs and how long? That will be led by Professor Davis, discussed by Armando Mancia and Professor Fakhri from Egypt. So thank you very much for your attention, and we'll go back into questions as we go forward now. Those that want to leave, So please, for our speakers, please stay on. And now I'm going to turn it over to our colleagues that are here at the medical school to see if they have any particular questions. So please step up if you do. We do. Please announce yourself, who you are and where you're from.
I'm Lukman. I'm from Australia, Sydney, and currently practicing as a pathologist. My question to Lina, thanks, great presentation. Do you flush reticular veins as well, or just the telangiectasias with a steady flush?
Were you able to hear the question? No.
No,
Can-
not well.
Okay, can we have the microphone, please?
Lina, thanks for the presentation. Lukman from Sydney, working as a phlebotomist. Do you flush the reticular veins as well, or just the telangiectasias after your treatment?
Lowell, can you repeat that? Sorry.
Yeah. We're going to use a particular microphone.
Thanks, Lina. My question, do you flush reticular veins as well, or just the telangiectasias after your treatment to prevent thrombosis and avoid hyperpigmentation?
Yes. I have heard the question. You? Do you? Have you?
I heard
If
it.
with the reticular vein in the same time as the telangiectasia, I think.
Yeah. Okay, that's what I thought I heard as well. Yeah, I treat everything together. I think it's all part of the same disease process. So yeah, I treat everything during the same session. I think for those who have varicose veins, more, real chronic venous insufficiency, superficial venous disease, obviously we do that part medical, take care of the varicose veins, just thinking about this almost like a tree, and the big trunk, and then going all the way out then into the smaller branches and smaller roots. We got to treat the entire system, and especially when there is a cosmetic motivation. So if there's medical, we address all of that, including varicose veins. And then as we jump into kind of a cosmetic phase, we definitely want to address those reticular veins while we're treating those telangiectasias, because it is very, very hard for the telangiectasias to completely go away and clear if we don't address the reticular veins that are feeding them. And a lot of times that takes doing an ultrasound. I can share a case of a patient who just had very superficial telangiectasias, very small. It doesn't look very, it doesn't look very significant, but if you look on ultrasound, especially on the thigh, I think on the lateral thigh, it's very important to try to look for, usually there's a reticular vein that is coming from a thigh perforator, like a lateral thigh perforator. It is going to be very hard to get those lateral thigh telangiectasias to clear up if we don't address that reticular vein that's feeding them at the same time or at some point. But yeah, in my case, we do them all at the same time.
Lina, Annalise, Lourdes, we didn't talk about facial blemishes. Comments?
So for face lesions, for face veins or any type of vascular structure, I think my go-to is laser for most of it. The ones where I personally use sclerotherapy is for the larger veins in the forehead. I do sclerotherapy for those. But for under eye veins,
foam or liquid?
foam.
Are you
Foam.
worried about the cavernous sinus?
I am, and I'm very careful. So I usually have someone with me while I'm doing those treatments. I'm having them apply very significant pressure in this area to, kind of like block there. Same with here, just sort of like holding the potential entryway. So yeah, absolutely. Like it's something you have to be worried about. I knock on wood, thankfully I haven't had an issue, but sometimes those forehead veins are so large that they're just too large for a laser to take care of even at 1064. And phlebectomies, I don't think are, obviously you can always try to do a phlebectomy, but I've just had really good results with sclerotherapy for those. But for everything else, under eye veins, little broken telangiectasias on the nose, like on the sides below the nares, venous legs, all of those things, the 1064 nanometer Nd:YAG works really well for me. I do a lot of aesthetics as well. And so I do treat rosacea. It's mostly with more like an IPL type of thing. And I do have a micropulse 1064 Nd:YAG laser, which is more for like that diffuse redness. But for the face, essentially for me, it's laser all the way, except for those larger veins, especially on the forehead.
Annalise?
I'm not that courageous to inject anything because people here in Brazil, they are like not that easy to handle sometimes. So what I prefer to do is use laser solely. And for these larger veins, I just tell the patient it's going to get better, it's going to improve, but that probably something's going to be there still. And as long as it stops popping up, they normally would be happy. It's just something that you have to talk to them before. There are a few people here in Brazil, they do endolaser for those. I don't do it. I refer. I say I prefer to refer than to regret. So I just send them up to somebody else. When it comes to something that I don't like to do, that I don't feel comfortable doing, I just I refer them. If they still want something or something to improve, I stop treating and I refer to somebody that's like more bold at some points. I'm very conservative.
Short comment, Lourdes.
I refer to, I don't treat veins in the face.
Okay, thank you. We have another question, please.
Hello, I'm Dr. Santiago de Salas from Argentina. Nice talks. Congratulations on that. My question is regarding matting. You mentioned the topical use of brimonidine.
Brimonidine, yeah.
There is a case report from Brazil with good results in a short time. Do you have any experience with topical use of brimonidine? Because it's used already it has been used for rosacea with good results also.
Yes. So I've only used it on one patient, so I cannot tell you that I have this vast experience, but I did, this was a few years back that I ran into a couple of papers where they have had patients with refractory matting, and brimonidine seems to, topical just started kind of like turning the curve for those patients. And so I've only used it on one patient, and it really worked for her. I have to say I was also using other techniques. So I was using IPL on her as well. And so it's hard for me to say that it was the brimonidine that did it all or if it was a combination. But again, there's at least some data, nothing solid, nothing very robust, but some few, case reports of brimonidine really turning the corner for these patients that are refractory to other things. So it's just another thing to have, another tool in our toolbox.
There was a question here. Oh, let me ask Annalise before we go. Have you any experience seeing that this is a Brazilian?
I've seen a few cases from my peers here because they're studying it. The problem is getting hard to get the brimonidine here. So you have to get the eye drops, send it to a pharmacy so they can manipulate it and make it in a topic solution for patients to use. Yeah. But it seems to be very promising. I didn't have the opportunity to use it yet, but Lourdes, I'm willing to try if needed.
Lourdes,
well, I think the most important thing managing hyperpigmentation is looking for the residual reflux under the hyperpigmentation. Many times you can find reflux that you can eliminate. This happens also with matting. And the time is a key point to wait and see And if the reflux is eliminated, the hyperpigmentation has to be solved.
Thank you very much. There's another question from the audience. Should we do Doppler studies in all cases of spider or reticular veins? And if you
Yes.
find reflux in the great saphenous vein, how should you approach it? Or should you not?
So I personally don't do it on 100% of my patients, but I have to say the vast majority do get it. And we just sit down and again spend our time doing a good history and physical. And I mean, if I have someone who literally has absolutely no symptoms and their telangiectasias are very, very fine, they're just few and far between, like nothing that is screaming anything, I probably won't do it. Now, I will have the conversation with that patient that our treatment may not be as effective or may, she may have a recurrence sooner if there is something underlying that we don't know about. So I do have that conversation in those very few patients that I don't do the ultrasound, because again, they're so completely asymptomatic and their spider veins are so teeny tiny and benign. But I do tell them that just so that in the future, again, if we're faced with a recurrence or a treatment that's not completely effective and satisfactory, then we can say, oh, okay, we had this conversation, let's go ahead and do the ultrasound and see. And then, that's a whole other discussion, because then, okay, should we be treating, then it's like, okay, so if they have it, but if they're asymptomatic, should we be treating it? So I think at the end of the day, it ends up all being about the conversations that we have with our patients, because let's say it's someone who's completely asymptomatic, but you do an ultrasound and they do have reflux, then, first of all, insurance is obviously not going to, you're not going to get support from insurance. So if anything, just having a conversation and almost like making that decision with your patient, if they're willing to pay for that, just so that, maybe their treatment is more effective, or trying sclerotherapy and then seeing if it doesn't work, then it's kind of hard. But I think at the end of the day, like with always, it's just having those conversations with the patients and trying to, everyone's different and everyone's expectations are different, but short answer is no, I don't do it on everyone, but the vast majority of my patients do get it.
Annalise, comment?
I do like a FAST checkup, like a screening Doppler ultrasound. I check the great saphenous veins for all of them. If there's something there that's not connected to the lesions I'm treated, I just put it on follow-up. If the patient is asymptomatic, they know that it's there and we are not assessing it. And I do the target lesions. I do the ultrasound of all the lesions. I measure the reticular veins that I'm treating, and I look for microperforators or everything that might be fitting the lesion before I started treating. So I don't screen the entire patient, but I do look at every patient's saphenous veins and also the veins that are fitting the lesions. So yes, I do it for all of my patients. I do it myself.
And do you treat an asymptomatic?
No, I don't treat any asymptomatic saphenous veins unless it's connected to the lesion and the lesion is refractory to treatment. So as I do as Lina, if the lesion is connected to the saphenous vein, I treat the lesion, and if it doesn't respond, I'll assess the saphenous vein later on if needed, and if the patient wants so.
Lourdes?
I do the same as my colleagues.
Javier, do you have a question? You need to come here. You need to come up here if you have a question. Javier is a sclerotherapist extraordinaire. He will ask a question in Spanish. If you understand it, please relate. Javier?
¿Qué piensa
Here, aquí.
¿Qué piensa del uso de glicerina crómica?
Ah, sí.
Yo personalmente no tengo experiencia con el uso de glicerina, tengo experiencia con polidocanol y con sotradecol solamente, entonces no te puedo decir, pero no sé, Lourdes, si tú tienes, I was just saying that I don't have any experience with glycerine, only with polidocanol and sotradecol. So Lourdes, ¿tú tienes experiencia?
I have
Noel, do
experience
you
with
want
glycerin.
us to speak in English or in Spanish?
Either one.
En español, por nuestro colaborador. Yo tengo mucha experiencia con la glicerina cromada, llevo utilizándola más de 10 años y de hecho es mi tratamiento preferido en las telangiectasias y también en venas reticulares. Lo uso en lugar de el polidocanol líquido o espuma, que es el otro esclerosante que tenemos en España. Es una mezcla que combina frío con un esclerosante de baja potencia y tiene pocas complicaciones, no produce pigmentación, no he tenido ninguna necrosis ni enfermedad trombótica venosa, ni tampoco reacciones alérgicas, salvo alguna reacción local. Para mí es mi tratamiento de elección en la escleroterapia estética.
Yo lo he utilizado algunas veces, como algunos años atrás, pero lo he intentado a mí misma. Yo lo he inyectado, todo lo que he inyectado a los pacientes, ya lo he inyectado a mí misma y me ha puesto como, me molesta. Yo creo que es un poco más doloroso que las otras opciones. Entonces yo lo he intentado, sí que funciona, sí que va bien. Si es la opción que tienes tú, la utilices, pero igual a mí ya no la utilizo hace tiempo.
Yo,
Porque...
de verdad, es que no he dicho una cosa importante y es que la utilizo enfriada. I do sclerotherapy, you know, we use a patented cryo syringe that put the chromated glycerin under 40 centigrados, you know, very, very cold sclerosant.
Esto no lo intenté. No, I didn't try it this way.
Yeah.
We didn't have it at the
Los
time.
debió meter en la nevera un ratico.
Sí.
Thank you.
Yes, but you have to get a very, very cold with a special cryo syringe.
Javier.
Tienes que utilizar con frío la crioescleroterapia.
Por favor.
Un momentito, por favor.
Que no he dicho antes que utilizo la... Ah, perdón, pensé que lo tenía que decir en español. Sorry.
Lo que pasa, doctora, que usted vive donde están los dos inventores de jeringuilla de crioesclero, digamos. ¿Prefiere alguna de las dos?
Tengo las dos. Tengo las dos jeringas.
¿Cuál le resultó mejor o es la que
bueno,
recomienda?
es que la jeringa del Dr. Ripoll ahora no se puede conseguir, ya no la fabrica. Yo tengo 3 del Dr. Ripoll y tengo ahora 2 de la criojeringa de Javier García Mingo. Y utilizo todas, son todas buenas, pero la que se puede comprar ahora es la del Dr. García Mingo.
Gracias, doctora.
Thank you very much. I appreciate that. I think that wraps up our questions from here at the National University in Asuncion. We thank you for staying on longer. Appreciate it. And thank you for speaking in English and Spanish. I had no idea what you were saying, so I'll find out afterwards, but I appreciate it. And
Victor can translate.
Thank you.
Thank you
Bye-bye
so
then.
much.
Thank you
Appreciate
so
it.
much.
Thank you so much.
Thank you.